Good morning. Today I will lecture about intra-uterine fetal death or stillbirth. What's the definition? Is the delivery of the baby with no sign of life after 24 weeks of pregnancy, and the incidence 5.5 per 100,000 of delivery. What association? Association. The association is not the same as the cause. The condition associated with the increase with the advanced maternal age, advanced gestation, and maternal obesity with social deprivation. The causes of intrauterine fetal death can be divided in three parts. The first part is the fetal cause, like cord accident, like cord prolapse, nose, torsion, thrombosis, fetal transfusion, like in the twin pregnancy, chromosomal genetic disease, structural anomalies, infection, anemia of the fetal origin, like alpha thalassemia major, which is incompatible with life, fetal maternal hemorrhage. Other causes, it's maternal cause, like obstetric cholestasis, metabolic disturbance like diabetic ketoacidosis, reduced O2 in pulmonary disease like cystic fibrosis or obstructive sleep apnea. Uterine anomalies like Asherman syndrome, which is intrauterine adhesion, which is mainly occur after uterine curettage and remove the endometrial basal layer, so the nutrient supply will be diminished and the fetus suffer from deficiency, and hypoxia will lead to intrauterine death. Antibody protection like congenital heart block caused by SLE due to anti-La antibody or Bell-Rhesus disease. What about the maternal placental effect? Like preeclampsia, renal disease, antiphospholipid syndrome, thrombophilia, which is increased tendency to cause thrombosis. How can diagnosis or how can the patient come with you? Other causes like smoking, drugs abuse, like cocaine, abruption placenta, and also 30 to 50% of intrauterine fetal death causes unexplained. يعني 30 ل 50% من الانترفين من ورا كل انفستيجيشن نعمله هي ما راح نلقى underlying cause فنعتبرهم unexplained intrauterine fetal death. How can be diagnosed? How can the patient present to you? 50% للبيشنت يجون suffer from the decreased fetal movement. 50% يعتقدون فقط انه قلت الفيتال. بعضهم can be diagnosed with unexpected finding by accidentally discovered during the routine antenatal ultrasound. نسوي لها routine ultrasound نكتشف انه الفيتال heart ultrasound. أو تجينا فد acute case as in placenta abruption with or without vaginal bleeding. نعرف two type of placenta abruption and then concealed bleeding or revealed bleeding. CTG عادة نشوف negative heart sound and present with rupture قد تجينا membrane, present with active flavor محتمل تجينا وتجينا with IUD. How can establish the definite diagnosis؟ نعتمد من أفضل شيء هل هو CT scan أم ultrasound؟ طبعا الألتراساوند is the gold standard for the diagnosis of intrauterine fetal. Why? Because cardiothomonography may be misleading because in the intrauterine fetal, the CTG may measure the maternal heart rate and consider it as a fetal heart rate, and this may lead to the misleading the diagnosis. What the ultrasound? What's the benefit of doing it? First one, to see fetal heart activity negative, can be see oligohydramnios, Spaulding sign, ومعناها overlap of the fetal skull bones if the death for sometimes يعني نشوف ما يكون all death حنشوف Spaulding sign. Also we can find the sign of fetal hydrops as associated with the RHS organization or the alpha thalassemia major. also can be abruption, sometimes with even patient should be examined for blood pressure, suspected preeclampsia, abruption, urinalysis for the albumin and the other for urea and serum uric acid. If the cause of intrauterine fetal death is abruption, the major sign will be of abruption first, tender uterus, tetanic uterine contraction, negative fetal heart activity in the major cases, vaginal bleeding positive or negative, يعني present or not. If we suspect the fetus died for some time from the spotting sign, like seen in the ultrasound or oligohydramnios or hydroxia, we can send mother for clotting screening to the rule out of disseminated intravascular system. What is the intravascular system? Yeah. And also completed per picture, they can count divided partial time for complete time, serum concentration level. In other words, our agitated and his has her husband, our agitated must have NTD because massive fetal maternal transfusion is one cause of the fetal death and may have occurred hours or even days before clinical presentation. If the mother RH negative, NTD immunoglobulin and plus for clarity, which quantitative is for the measurement of the volume of the fetal maternal transfusion. Because the standard dose of NTD cover only 15 cc of the fetal blood, so we need to increase the dose of NTD of immunoglobulin to amount of the fetal blood in the maternal blood to prevent sensitization. يعني البيشن إذا كانت هي RH negative زوجها RH positive بيحتاجون prophylaxis to prevent sensitization should be take anti immunoglobulin بس يجب أن نقيس نعرف أن الستاندرد دوز يدنا فقط ل 15 سي من الفيتال بلاد لا تنسوا الكوانتيتيف تيست بير تيست the maternal to know how much the fetal maternal transfusion محتمل نزيد الستاندر إلى الeffective dose. Management. The first thing and the important things is psychological support. خليتها أول نقطة لأن جدا مهمة لأنها وندرج الخبر لهم بالتدريج لأن مو سهلة إنه ينتظرون fetal development وتحتاج لهم إنه fetal heart negative and pregnancy end with failure. Psychological support is very very important to mother and his family, her family, and her husband and family. Investigation for the cause. Mode of delivery is important. Prevent RH sensitizations, important suppression of lactation, postmortem examination, and follow-up and management for further pregnancy. هاي 8 نقاط ملخص بما راح كل نقطة راح نتابعها سويا. شنو الانفستيجيشن؟ احنا ليش بنسوي should be so should be vaginal this is delivery by cesarean most. Various strategies use the induction of labor after the fetal death. It is important to remember that complications such as rupture uterus, shoulder dystocia can occur and management must be safe. The patient should be treated as in the normal labor. So the progress of labor should be monitored. Only the fetal heart is not monitoring. This is only the difference. The third trimester induction of labor is by central prostaglandin preparation. Other method can use of antiprogesterone, mifepristone, and plus prostaglandin alone misoprostol. This important use of mifepristone because it will decrease induction labor time. Use 200 milligram orally 24 to 48 hours before induction. Then misoprostol 200 microgram vaginally, then 200 microgram every 3 or 4 hours orally. What's the difference between normal labor and induction of labor؟ كم نقطة لازم نعرفها. شنو فرق غير إنه ما نفحص الفيتال heart؟ إنه الممبرين should be intact as long as possible. ليش؟ Because risk of the chorioamnitis, ascending infection, sepsis is rapidly occur when present intra-uterine fetal death. In culture for dead tissue culture for growth of postpartum hemorrhage not uncommon, especially when preeclampsia or abruption or prolonged interfetal death, even more than 4 duration only. Increase the risk of retained placenta because of prolonged chorioamnitis and repeated small abruption, so antibiotics should be given in this case. Investigation for the cause. نبدأ أولا investigation for the baby to know the underlying cause. Careful examination of the baby forces any structural anomaly. Weight the baby. Weight the baby if it's macrosomia. Weight the placenta if it's small or large. Size of ribcage present or not. Morphology and abnormality. Determine the sex of the baby. We can need even pediatrician help, maybe fetal blood for infection screen and karyotype, fetal skin for karyotyping if it is blood available, full fetal X-ray and notic fluid should be taken for cytomegalovirus, anaerobic and aerobic bacterial infection. What the investigation for the mother? Maternal blood taken for infection, autoimmune disease, anti-nuclear antibody, robust anticoagulant, anti-cardiac antibody, anti-ro, anti-la, thrombophilia screening, pre-mitigated hemoglobin anyway, 1C for sugar test, never do the blood sugar in the normal. BAL test if it is there is intrahepatic cholestasis for pregnancy, clear test for regardless blood group for the RB and any fetal maternal hemorrhage if it is RH negative and other RH positive. Anti-Ro if the antibody if the fetus is hydros, maybe this SLA, maternal genital tract swab infection, maternal menopause drug screening. For the investigation for placenta, weight the placenta, swab for infection, sample for the karyotype put in the normal saline and sent to the lab. All placenta should be sent for histopathology, calcification, thrombosis, suppression. النقطة اللي بعد حيكون suppression of what? Of lactation. Suppression of lactation by the simple measure analgesia may be the express encouragement and is painful. Single dose of double choline long-acting dopamine agonist highly effective. Contraindicated in the patient with a preeclampsia or with thromboembolic disease. How can follow up the patient? The first things also psychological support. The first follow-up visit should be during or after the first 6 weeks. During the period, investigation should be repeated to identify the possible treatable cause and follow the previously said. يعني شنو؟ إنه نحاول إن نعيد اللي طلع investigation screening process نحاول نسوي لها diagnostic test وقدر الإمكان نجد اللي treatable cause حتى to prevent occur of the IUD in the next pregnancy. If you don't reach the cause, you consider the next pregnancy is a high risk pregnancy. حكينا بالمحاضرة عن disseminated intravascular coagulopathy. شنو نقصد بيها؟ ليش تصير؟ هنا state characterized by degree of decreased fibrinogen, plasminogen, anti-inflammatory, and platelet, and increase in fibrin degradation product. It is occurred due to pathologic activation of the clotting cascade, which is demonstrable within 48 hours of the demise. The incidence of it increased with the duration of the delay. Less than 2% of these women experience a hemorrhagic complication, and coagulopathy resolve within 48 hours of